Good afternoon, everyone. On behalf of the Women's Caucus of the American Public Health Association, I want to thank you for joining us for today's critical discussion. This is the first in a three-part series on federal funding cuts, the threat to women's health research programs and services. My name is Nala Loden. I'm a healthcare attorney with Wilson Sonsini based in our Washington, D.C. office. I specialize in digital health and women's health law, and I'll be serving as your moderator for the next hour. We're living in a time of urgent concern for women's health and the future of women's healthcare. In recent years, we've witnessed a troubling amount of challenges, from the rollback of reproductive rights, the rising maternal mortality rates, especially among Black, Indigenous, and other women of color, to growing attacks on gender-affirming care and access to health services for LGBTQ individuals. Structural racism, discriminatory legislation, and widening health disparities continue to erode the trust and limit the access to life-saving care. Now, with both proposed and enacted federal funding cuts, we face an even greater threat, one that targets the very research, programs, and community services that form the foundation of women's health, gender equity, and public health progress in this country. Today's conversation is about making that threat visible. It's about lifting the voices of those who are leading the community-based responses, advancing innovative research, and shaping the programs in the face of the shrinking resources. We're honored to be joined by three incredible panelists who will share their insights. They're the experts. I'm here just to support them, and what to do next to protect the progress we made and to push further. Our panelists include Angela Ellison of the University of Illinois, where she serves as the Senior Director of the Office of Community Engagement and Neighborhood Health Partnerships. Dr. Karina Villalba, Assistant Professor at the University of Central Florida, where she specializes in population health sciences. And Dr. Heidi Steinecker, the Principal at Resultant Consulting, and she was the former Deputy Director at the California Department of Public Health. Before we begin our discussion, just a couple of notes for everyone who's joined. The session is being recorded, and we'll share a link with all the registrants. You're invited to share your thoughts or questions in the chat box throughout the discussion. We have reserved time towards the end for a group reflection and a brief Q&A, so I'll be monitoring that. And feel free to engage with us throughout the discussion by using the reaction tools that you should see on your screen as well. So to kick off, we're going to have Angela Ellison just to get the conversation going. You've worked extensively with the coalition addressing maternal and child health, chronic health disease, and behavioral health. Could you tell us how federal funding cuts threaten these community-based efforts?
Absolutely. So first I want to say thank you. Thank you to the Women's Caucus for allowing me to have this opportunity to talk about this very serious issue and the cuts that we are facing. I will tell you, I've been doing a little bit about me just for a quick second, is I've been doing maternal and child health since the mid-'80s, when Illinois had its first infant mortality reduction initiative. So I've seen the changes over time, but I will tell you, these are some of the most unprecedented times I think we're all saying that I've ever seen. We've made a lot of progress in these 30-some odd years in addressing infant mortality, but right now we're looking at an opportunity for us. These federal cuts will send us back probably beyond 1986, where the numbers of infant mortality rate in the communities that we serve was as high as 28 deaths per 1,000 live births. We've got it down in Illinois to somewhere in the neighborhood in some of our worst communities, still up there around 17, sometimes 13 and 14 in some of the communities I serve. So the numbers are come down, but there's still a lot more work to do. And this is the worst time for these cuts to be happening. I actually run a Healthy Start program, which is a federal initiative that is on the chopping block to be cut. We're looking for reauthorization of that. We've been operating Healthy Start since 1991. There's actually 115 Healthy Starts across the country, some serving some of our neediest populations in addressing infant and maternal mortality. And so, and I also sit in the Illinois Maternal and Infant Mortality Task Force for African Americans. So we are looking at these numbers and at these cuts to potentially have deep diving cuts for the families that we serve. We provide very vital services, support services, connecting them to resources, actually giving them transportation. The infant mortality rate, as I indicated, is still not where we need it to be. But Dr. Arthur James, who's a phenomenal name known in the maternal world, shared some data some years ago in Region 5 that if we don't do anything about the infant mortality rate, things don't change. He calls it the crude survival lag. And what he says there is that if things don't change, African American babies will not achieve the infant mortality rate until 2044 that white babies achieved in 2019. So he says if things don't change. So now things are changing, but they're changing for the worse. So can you imagine what that number looks like when it comes to infant mortality? So when we're talking about infant mortality across the country, we're sitting on the tip of what could be a very, 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 very fall drop in addressing maternal and infant mortality in this country. And it's happening across the board. I'll use another example. If I step out of the maternal mortality space and talk about the food space, we have another program that's a SNAP Ed initiative. It's a SNAP program where we provide nutrition education that is on the chopping block to be cut. That's a $4 million grant for us. It's about 500 million across the country. And it is a program that provides nutrition education and nutrition support to families in need. In Chicago, I'm not seeing food lines the way I'm seeing food lines now. It is unprecedented. The Greater Food Depository, which provides a lot of that supplemental food to fund our food pantries, is already gone into crisis mode because they understand that if SNAP Ed, which is on the line, a part of this big, beautiful bill to be cut, will significantly, to numbers we can't even imagine, affect the people that we serve. So at the end of the day, these cuts are going to have a massive impact. And the fact that what they're proposing is they pass the buck to the states, unless the states have suddenly grown a money tree, I don't know where that money's going to come from. So that I'll shut up there because I can keep going on and on.
Yeah, no, that's so helpful, and thank you for all of the amazing work that you do. I have two little ones, under 3, and I've always very closely followed, as a healthcare attorney, maternal mortality issues. As a mother of color, I've followed this all very, very closely. My family are refugees from Afghanistan, and when I had my first baby, I was following the really astounding rates of maternal mortality for women of color of the United States, and it was akin to women in Afghanistan. I
Yes,
could have had my children in Afghanistan and been almost as safe if I were to have them in the United States as a mother of color. So
yes.
it really is outrageous to see those numbers. But as a longtime leader in the community, what sort of immediate funding or policy shifts would you recommend in order to sustain the work that you're doing? What is the first step we can do?
Yeah, Congresswoman Laura Underwood had developed an omnibus bill that is supportive of the maternal and child health services across the lifespan, because that's what we have to look at is policy that affects women. Like here in Illinois, we are fortunate enough to be in a state that is very supportive of maternal and infant health in Illinois. So we were one of the first states to pass legislation that allows women to have care postpartum for the whole year postpartum, which is important that their Medicaid benefits continue to be supportive that first year after pregnancy, because we understand that when it comes to maternal mortality, that usually happens within the first month to 6 weeks postpartum. My own mother was, and this is one of the stories I shared, one of my own mother was sadly one of those numbers, and that my sister died. My sister was born on November 26th. My mother died on Christmas Eve in 1969. 3 weeks after my sister was born from pregnancy-related complications. So I understand this not only on a mental space, but in a heart space. I understand it in that way. So what we need is policies around hospitals and care for the hospitals. At the basic, we need hospital reform to really look at implicit bias and all of those other issues, and talking about training providers up. Because I also have a doula in my program, and she shares stories around what she sees in these hospital systems and the inconsistent care that women get. So we need policies that support that, not less policies, more policies that enforce support for women of all colors as they give birth. Then we need policies to build infrastructure. I often talk about this, is that at the end of the day, we're talking about poor people. We're talking about poor people who don't have advantages. And when I look at the communities that we serve, there's no reinvestment in those communities, those reinvestments for businesses and support. So we need investment in that. And we need policies around holding people accountable and building an infrastructure that is for at every level, because we understand, and people often throw this word around, social determinants of health. And it's very important, is that we've got to help people at every level and develop policies that will impact them. And one of the ways I say you do it is you build a stronger infrastructure, reinvest in those communities, in buildings and housing. One of the greatest needs our mamas face, our babies and mamas face, is finding good, adequate, quality housing. Besides good quality healthcare and working through a fractured healthcare system, they also need a place where they can call home and feel safe.
Thank you for that. And to your point, these policies and these programs are helping a different population. Just to share another example, when I had my daughter last year, I had somewhat of a complication towards the end of my pregnancy, and I had to advocate for myself to the point where I brought my husband to an appointment to get to the doctor to hear me. And it turns out, and I'm not a doctor, but it turns out that it was a serious complication. And I had an emergency C-section within 5 hours after I asked them to run the blood test. And I went back after, I had my baby, and I said, if I didn't speak English as well, and I wasn't a lawyer who was able to advocate for myself, how many other women who, were not able to advocate for themselves could have lost their babies for this, this exact issue?
Thank you for that, because you reminded me to say this when it comes to policy, is also building policies that provide reimbursement for important places where, like doulas and community health workers. I know we're going to talk about community health workers, but in having places where we can have reimbursement for doulas and community health workers. Here in Illinois, we recently passed legislation that was working towards that. We've just created legislation has passed, and there's now reimbursement for doulas. However, what the challenge is if these Medicaid cuts happen, if these cuts happen, then the states have got to make decisions where they're going to be able to put their money. Do they support Medicaid broadly, or do they continue to support these smaller initiatives like reimbursement for doulas? In their mind, where do they put their money? Because there's no new money coming in if the federal government makes those cuts. So this policies like that, reimbursement for those supportive services, because when it comes to people of color, having a voice, oftentimes our women, and we've done lots of conversations, lots of steering groups, lots of focus groups, what the data shows is what women of color say is they don't hear me. They don't hear me when I say I'm in pain. They don't hear me when I say something's going on. There's lots of documentaries, Aftershock and others, that are talking about this very story where women were bleeding and the nurse walked past and says, oh, they're not a priority right now. So they ended up dying. So it's all of those things that we have to address as we move forward, and giving people a voice. And I just want to raise this issue because you said something, your husband came in there. When our fathers go in to advocate, they may be put out of the office because they're seen as violent. So we have to think about racism and how it plays a role in all of what's going on when it comes to full care for our families and our women.
Thank you so much for that. Dr. Villalba, just shifting to you and some of your expertise, your research focuses on the intersection of gender-based violence, substance use, and mental health. How do the federal funding gaps now affect the services and access for the women that you study?
Thank you. Well, first of all, I want to say thank you for inviting me to this very important webinar. I've been doing this type of research for over 15 years. And again, I'm going to say just initially, my collaborator said, I haven't seen this I have never seen it actually. These NIH cancellations and budget reductions are affecting everybody. So I'm just gonna say, first of all, it has at least affected 2,100 research grants. We're thinking this is totals about $9.5 billion of grants that were terminated up to now, halfway down the year, from the beginning of 2025 to beginning of July of 2025. They additionally are proposing, or at least have proposed, to freeze other grants disbursements and capping indirect costs at the university. So that has affected me in many ways. Number one, more than half of my grants have been terminated. I have very few grants on the proposed freezing, which I don't know whether they're going to continue or not. So I'm not sure whether in the chopping block or not. People that program officers in NIH that I used to talk to, and I would talk about the research. Usually when you submit your grants, there's a program officer that kind of guides you through the research, the implementation side as well. With close to 1,200 people being laid off in NIH, there has been a constant change of different people. Like 1 week you get one, the next week you get somebody else. Nobody knows what's going on. So it's been chaotic, to say the least. And now with this new budget proposal, they're looking to slash about 40% of the current NIH funding, which we're talking about from $47 billion to $27 billion for 2026. And then in addition to that, they're proposing to probably eliminate the NINMH, which is the National Institute on Minority Health and Health Disparities, which by the name itself, helps minority populations. The research that focused on minority populations, no longer that institute, we will be able to submit to that institute, or at this point, I don't even know if we can even use the word minority when we're writing grants. They're also proposing to get rid of the National Institute of Nursing Research, which again, that part of my research, part of my grants that I've submitted to were to both of those two different institutes, including others ones as well. So now if we want to really focus on what's going on a broader perspective on women's health in research, let's think about the Women's Health Initiative. This is right now in threat of being cut as well. This was initiated by the National Health and Long Blood Institute over 30 years ago, and it has been essential in developing guidelines around hormone therapy, heart disease, and cancer, which saved close to $35 billion in costs and now is in jeopardy. Another one that I'm very close because I do research on this area as well is that they initially paused research on long COVID. Then somehow it was reversed. So now they're continuing doing this research on long COVID, which is great. Now, why is it important for women? Because the effects of long COVID on women are different than on men. There is a higher risk on developing long COVID on women than on men, and on these very different symptoms, which there's several. And so this research needs to be continued so then we can see those differences. So luckily, in that regards, that research has continued. So that's one of the grants that in my case, they initially paused them, but now I can continue doing that. If we move into the maternal health world, there has been this initiative, which we talked about earlier, where they were looking to reduce maternal mortality among Black and Indigenous women and women of color. Now, because of this cut, it seems that this initiative is going to be as well also eliminated. I also do another area that I've been doing research focusing on substance use is being HIV research. Part of the research that I was doing was focusing on prevention research, outreach, and talk about PrEP access for Black, Latino, and the LGBTQ communities. Now, many HIV research grants, the ones that are actually focusing on on the communities that I just mentioned, on Black and Latinos and the transgender communities, all those grants have been terminated. So those grants in my case have been terminated. So then what does this mean? So we're like regressing. We can revert the progress that we have done to ending the HIV epidemic. Now we're regressing. We're going backwards. Similarly, with the substance use programs, in NIH alone, they haven't done any cuts per se, but they are thinking about restructuring SAMHSA, NIAAA, NIDA, and NIMH. So NIAAA is the National Institute of Alcohol and Alcoholism. NIDA is the National Institute on Drug Addiction, and NIMH is the National Institute on Mental Health. So what they want to do is get all these 4 different institutes, which each one of them focuses on a specific area, and they want to combine it into a behavioral institute, and therefore threatening harm reduction programs, postpartum treatments for women. Really, this $1 billion program, they want to reduce it into something much more smaller, affecting public health outcomes. And then finally, when we talk about trauma and violence, the DOJ cut about $145 million in grants. But I have to say that for the Violence Against Women office, initially they had froze or quietly removed many of those announcements. But now they are back. Now, a lot of times we don't know why these things happen because there's so much there's so much going on, right? And sometimes they say one thing and they do something else. Somehow now these grants are back because I just submitted 2 OVW grants, which is great because both of them focus on domestic violence and sex trafficking for women and youth. So that's something that I think is important to bring up because it's kind of the light at the end of the tunnel, we can say. And I did also find another announcement in NIAAA, which also is focusing on domestic violence. Why to me this is important? Because before 2025, before the Donald Trump took over into office, there was an emphasis on women's health. There was an emphasis on focusing on violence against women. There was an emphasis on focusing on all this type of NIH research focusing on women. All that was taken away, in a sense. And now we're beginning to see something coming back. Is never going to be at the level of what it was before, but we're hopeful that things will change, and we're really, really hopeful that the Congress will not approve this current budget where they're going to slash 40% of the NIH budget, because then I wouldn't know how that would affect really women's health research, because most likely that will be more than ever in the chopping block of what they're proposing.
Yeah, thank you for that. I think what's so interesting about all of these cuts that you've mentioned is like we're not really discussing the elephant in the room. I think their thought is we're saving funding by cutting everything, but the point of research is tenfold, right? Prevention is cheaper than treatment. If you do the research, you can reduce chronic disease or these issues later on. If there's better treatment, there is less waste. The current administration is concerned about waste. Research creates care efficiency. It cuts unnecessary procedures, unnecessary hospital stays. You create smarter care models. You have a healthier workforce, so that's a lower indirect cost. So, it's so short-sighted to say, I'm just going to cut everything, we're saving some money. No, you're not, because the point of the research is to prevent all of these systemic illnesses and diseases. So it really is just almost comical to me to be like, oh, this is easy. Let me just cut everything. Look, we saved a ton of money for maybe in this moment, but not, down the road. So one follow-up question there, sort of what role does translational research play in making the case for sustained federal investment in women's mental health and trauma recovery?
I will answer to that, but I'm going to add something to the prevention, because I think it's
Sure.
really important to talk about that, especially since we're here, representing APHA. I think that prevention in general has been overlooked in general, but more so now, because it's always been geared towards treatment. Public health focuses entirely on, yes, treatment, but more so on prevention, because like we feel that prevention is the key to lower costs. Prevention is the key to better quality of health, of life. Prevention is the key to reduce any mental health of substance use. And unfortunately, with this new administration, that is more so now in the back burner. I think that if we go back to HIV, if we go back to substance use, if we go back to trauma and violence, I think that if we were to build the prevention infrastructure, then you wouldn't reach to those levels where, for example, increased mental health issues, and then that loop mechanism where they will probably use drugs and alcohol because they have this trauma, and then develop really some type of preventative measures for that. And the same thing for physical issues such as diabetes and issues that affect women. So I think that today, prevention for women it's not, and in general for everybody, really, it's going to be even worse. And I don't know what the outcomes are going to be. I mean, you're seeing what's going on with the CDC. So we don't even have access to data for us to analyze, researchers, right? Because that has been taken down from the websites. CDC, whatever data was there, we had to actually grab that before they will remove it. So then we can use that data, the new data that is coming in. I don't know what kind of data is going to be. So that's very unfortunate. Then because we won't be able to know the trends, we won't be able to keep up with what's going on. So then how are you going to develop research programs? How are you going to develop even treatment programs? So you won't have an idea if we keep going this path. Having said that, when you ask the question about translational research playing, making a case for sustained federal investment in women's mental health and trauma recovery, I think that translational research is critical. I think it's very important because it bridges this gap, right? It's going from basic science, which is done, then goes to clinical practice, or clinical research, and which then goes into population health implementation, and then which reaches to policy change. So there's this trajectory with translational research. Where are you in the translational research you are depends on the type of research somebody's doing. So for example, in the HEAL initiative at NIH funds translational research for women for opioid misuse with trauma histories, which has informed federal programming for several years. Another example is SAMHSA with the maternal opioid misuse model, which has shown measurable improvements in prenatal care engagement, has shown reduce in opioid misuse, postpartum overuse, and infant complications. So these outcomes has helped policymakers justify Medicaid reimbursements, for example, as well as how to support then additional federal funding. So if we were to put it into this context of what the federal government is focusing or what their priorities are today, for example, if we look at translational research focusing on trauma recovery and interventions for women with substance use disorders, then with this current NIH directive that focuses or emphasizes on the important on sex as a biological variable, then we can look at, let's say, life course approaches of mental health and substance use approaches, because then that will focus on, the sex differences. So that will be, in this current climate, something that can be achievable, let's say, if we were to do research or focus on these NIH directives now that we are being told that we're not being told on what kind of research we need to do. I have to make that clear. We are just being told on what the NIH directives may and what NIH may support or may not support. So it's up to the researcher really, how whatever their goal is and whatever approach they want to make is, then how they want to conduct their research based on these initiatives. And it's also, I have to add one last thing. In addition to that, I live in this Florida, which is the state of Florida, which the public universities, in addition to what we can say not requirements, but suggestions come from the federal government. There's also a law in Florida that mandates what type of populations we can focus on when we want to do public health programming or when we want to do research. And I'm going to say that we have to be very careful because we cannot include women of color. We cannot include LGBTQ. We cannot include violence. So in our narrative, we need to be aware of what we're including and how we're going to be conducting this research. So when I said that we can do this, the sex biological variable as research, then that we can include because it would be women and men. So I just want to bring that up because I thought that was important in comparing our state with other states. I'm sure other states can have a broader view and area that will align with the federal government, but we need to align it with the state and also with the federal government.
No, that's a very helpful tip, and it's a real issue. I can tell you in DC, I've lived here almost my whole life, and one of the craziest anecdotes that I've heard in the last couple months was DOGE was going through different grants, and they essentially controlled F searched the word transition and deleted all of those grants. And some of the grants just use the word transition. And one example was like transitioning students with ADHD into like public school system. But it had nothing to do with the issues that the federal government was concerned about cutting, but it was just simply using the wrong word. So that is certainly a helpful tip for our listeners. Dr. Steinecker, based on your policy and systems leadership experience, how are state and federal funding cuts undermining public health infrastructure for women's health from your perspective?
Thank you. I want to first say again, thank you to APHA and the Women's Caucus for having this very timely conversation, particularly in a week where we found out that SCOTUS also stated that states can go ahead and defund Planned Parenthood, which provides so much access to health care to women across the U.S. and to men. They provide a variety of services that are critical for family planning, contraception, health promotion, and education, among other types of services that unfortunately women will further have issues with access, particularly in rural areas. So my background is both in healthcare and public health, and where government meets policy and actual operations. And so when I see these potential cuts to Medicaid, in addition to the cuts that have already taken place, My biggest fear is rural health. We have so many hospitals, health clinics, FQHCs, so many different types of healthcare facilities that will eventually close because of these cuts. The way that the payer mix works in many different types of healthcare institutions require that there be a funding element for, CMS and Medicaid and serving these populations. And these rural health centers already, many of them over the last few years, have closed down their labor and delivery departments. In fact, the hospital that I was born in rural California no longer delivers babies. In fact, people in the same city that I grew up in, same city where my family still lives, they would have to drive 30 minutes to 45 minutes. And that's on a positive scale, just for like a tertiary hospital, not for, if you needed some sort of extreme measure of care or, NICU, et cetera. And so we have people all over the US, and I've worked with multiple different states and counties on this access issue as they're watching a lot of these different facilities close down either completely or they're closing down their service lines for women's care. And that's the thing that I think that we need to be working with state and local governments on what is their plan of action for whether they are looking at heat maps of where these healthcare deserts are, whether they are using data to look at where the highest risks are for women in the populations that are of childbearing age, whether they are also using this information to be able to then kind of upskill and reskill and move different workforce to these areas or incentivize workforce to work in these areas where healthcare deserts exist. And then also, the addition of private-public partnerships between healthcare systems, local public health, and having different mobile clinics, community clinics, working with CBOs to be able to increase access for prenatal and postnatal care. That's going to be really key over this next year. The other thing that I see that is really troublesome that we need to start planning for now is even just the shift in the ACIP committee over at CDC when it comes to how are we going to be advising vaccinations for women, pregnant women, children, and some of our most vulnerable populations. And what people don't understand is when you're using pseudoscience and you're not using actual evidence-based research that is showing for decades the proof of how vaccines are so critical to our communities for their health and their welfare, um, then you run the risk of, okay, insurance is not covering, right? And if insurance doesn't cover, guess what? Manufacturers will not make as many because there is no ROI, right? So it's this downward spiral of where we will have less access to care. You will see people in a high income country like the US have to go to other countries to get their basic vaccines, which is sad and not okay. I was just in Uganda last summer, working a vaccine clinic in the Bwindi impenetrable forest, the forest that has all of the wonderful, fun infectious diseases, right? It is one of those hot spots of the world. It sits on the corner of Rwanda, the DRC, and Uganda. And I was in a village vaccinating, working with villages all day. And one of the healthcare workers came up and said, "Is it true that in the US there's people who wouldn't want polio vaccine? Is it true that these vaccines that people have walked barefoot for half a day to get access to from the WHO and USAID and all of these outreach efforts that they wouldn't take them?" And they
I
were
have
just
to I have to interrupt because that's a story I've repeated to many people from my family in Afghanistan, like verbatim. They're like, we remember we would line up outside of Red Cross tents and everyone was begging, please vaccinate my baby.
Yeah.
So
Because
that,
when you watch
yep.
people in your village die, when you watch people that, have no access to healthcare suffer, right? You see the value in it, right? And somehow we've lost that along the way, unfortunately. So, I do have this perspective of working with multiple different states and countries and then local communities. And what I see is that we have more in common than we don't, whether you're a blue state, red state, purple state, right? I work with all kinds. And the reality is it's all about you need to preserve that access to care, and you need to be able to preserve quality access to care, quality and safe, not just, oh, hey, they got seen. That's going to be something that we're going to have to be able to use data and modern tools to be able to do more with less resources.
Thank you for that. And are there any innovative models that you've seen across, states or internationally that the US could adopt to better protect women's health during these financial downturns?
Yes. So when you have low income resource countries or even a high income resource country like ourselves, who's going to defund a big part of our healthcare system, the key is, you need three things really to do healthcare, right? You need a space, you need supplies, and you need staff. And I have found people all over the world, and even during COVID here, people being really creative with space, right? You can turn an old church into a vaccine clinic. You can turn a gift shop into an ICU room with enough creativity and engineering. So I have seen that happen. Space, that's solvable. Supplies is the next issue. Supplies, of course, we saw those huge issues with supply chain, and we're going to continue to have risk with our supply chain, particularly because of the tariff situation and trade situation and our over-reliance on a variety of different medical tools all over. But even then, you have seen that people can get really creative or find ways to decontaminate and reuse things for multiple use. There's ways to do work with supplies. But the one thing you cannot solve for, you can't AI it, you can't 3D print it, is a specialized nurse or a specialized midwife or an OBGYN. Like there are certain skill sets that you need that we don't have enough of. And yes, we are trying to upskill and train and bring in a new workforce. However, you can't be in all places at all times anymore. And so a lot of what I do when I'm working with different healthcare systems or counties, states, a national government is we look at, okay, what is your most critical workforce and where do they need to be that is at the highest risk locations because of either your case fatality ratios from maternal health, whether they be your case fatality ratios from infectious disease or healthcare acquired infections or other things that can come up in the access and quality issues. And so what we do is we look at different data sets. And I agree with Dr. Villalba here about that we are losing critical data sets from CDC, but we can work with what the primary sources were, which those data sets originated from states. They originated from different healthcare systems. We can work with those local county jurisdictions to be able to use those data sets to be able to provide better visibility and be more proactive. And in addition to being proactive, we've also found that you can play with predictive analytics. You can forecast where you're going to have these healthcare surges when you see different national, or natural disasters come through. You can forecast where you're going to need more EMS or supplies or people when you're able to look at, oh, here's a situation that has traditionally in the past been a problem. This has been a hot spot for our state. We always have too many people and not enough hospital beds or resources in this one location, right? So you can start to plan for mitigation. And that's what I think we need to start doing now is working with our leaders on how they can be able to use these tools, particularly like mobile resource tools for their field staff, and being able to do more proactive work and being able to mitigate and be able to push those very critical limited resources to those areas.
Thank you for that triage advice. I think hopefully it doesn't come to that, but it's great to know we have experts that can advise if it does. I'm going to turn to some group questions for our panelists, but in the meantime, I invite all of our listeners to send in some questions while we go through these, and we'll open the floor to Q&A. But for our panelists, how can cross-sector collaboration, including academia, policy, and community leaders, align against the impact of fluctuating federal funding on women's health?
Well, I'll go ahead and just start because I had mentioned this whole idea of a private-public partnerships, right? Where it used to be, healthcare systems sat in one silo and your government and public health sat in another silo. We learned obviously during the pandemic that is not helpful for our populations, right? They have to integrate and share resources. They have to integrate and use their data to be able to have better visibility, line of sight, and be able to work together to provide access and quality of care. But another piece of that now, as we saw in this last year, is when we saw the disruption to our food chain, right? Because we now know, oh, where's our animal health data? Oh, it sits over here in a completely different bucket. Oh, and on our environmental health data that also affects women's reproductive ability. Oh, that sits over here. And so we're needing to have more of this one health approach. And that does take academia, government, healthcare, our animal and veterinarian partners, as well as our environmental health scientists, being able to pull data and be able to share resources and be able to share insights across to see where these kind of triangulate the data and see where these kind of heat risks are. The other parts where I see this is I serve as a U.S. citizen diplomat for the Department of State. I've served in that role since 2020. And so I have worked with, disease surveillance and healthcare ministries of health from around the world in different policy discussions, right? And I think what people don't realize is our national security and our economic health is all based on our ability to keep our population safe, our ability to keep our military personnel, particularly our women abroad, safe. And so when I'm working with different delegations that are coming from different countries, often in conflict potential areas, that's all part of that policy discussion as far as how are we able to maintain access and monitor and be proactive with keeping the population safe, particularly during geopolitical instability.
Just one point you brought up, Dr. Steinecker, is actually a question from the audience. You mentioned environmental data and how that impacts women's reproductive health. One of the questions from the audience is how does infertility care, how is it impacted with all these federal funding cuts? So I just wanted to open that to the panelists to hear their thoughts, about people's access to care when they're trying to get pregnant, are pregnant, or navigating loss or postpartum.
Great question. I'm happy to hear from others on the panel, but also when it comes to yes, infertility, hormones, different pesticides, different things that get into either our water systems, our food systems, all of those things impact us, right? With our fertility abilities. And particularly, I'm concerned about these cuts this week or potential cuts to, Planned Parenthood and other access to reproductive care. Because of this, as people are trying to either become pregnant or they are trying to access care throughout the duration of their pregnancy, no matter how short or long it lasts. And even, I myself had a late-term miscarriage that required a D&C that I am so thankful that I happened to live in a state where I had access to that health care to keep myself safe and for the rest of my children and my family that I'm with. And so I think that, again, we can't continue to do this state by state because there are women, the American women, who are struggling and scared and will die from some of these decisions, unfortunately.
Absolutely. And I will add, I'm fortunate enough to live in a state that's a safety net state. So we're getting folks from all over the place. So you keep putting a lot of pressure on a state and on our system, then we're going to ultimately collapse as well because we can only have so many resources. To what Dr. Heidi was saying is that we only have so many resources and so much space and so many providers and all of that to support what we're getting in here in Illinois. So, and to your first question about the intersection is I happen to sit in an academic institution, but I am a program that serves the community, and I'm also in the community building community relationships and also working with legislators on sustaining these programs. What I know And what I've seen over these 30 some odd years I've been in this space, it definitely takes it's going to take this time a real stop. Let's not go into our little huddles and work from our silos. It's going to take time we're going to have to get together and talk about how do we attack this problem collectively as academia, because our academia, University of Illinois, is facing millions and millions of cuts in research. To Dr. Karina's point, we're facing lots of cuts in all of our program around maternal and child health and so many others. I could go on and on. So we cannot afford this time to go into our silos. We have got to figure out what that looks like. I don't have the magic answer, but I'm going to be working on it to figure out how we break down these silos and begin to work together.
I want to say that I do agree with Dr. Heidi and Angela. On our end, we just partnered with one of the largest hospitals in Miami, in South Florida, and we are trying to collaborate within academia, which is research, the hospital, which is not research based, and the health department on how to improve maternal health, because we do know that the biggest issues and maternal mortality and infant mortality have seen about the largest one is, especially the largest risk is for, and I think this was mentioned before, Black women. Then we talk about women of color, Hispanics. And if we look at the area of South Florida, more than 50%, I think it's 67% are minority women. So how are we working on this initiative? We're rolling our sleeves and we're getting together. We are not focusing so much on really grant funding because their grant is already there. But what we're trying to do is when combine these services that are being provided with research. How do I say that, or what do I mean by that? Is by being able to track the impact of this initiative, right? Because not just by providing services, for example, which in non-academic hospitals, they track it in a different way. But if you want to track it in a way where you're able to then show the impact in academia, show the impact and publish it in scientific journals, demonstrated with numbers, right? Following a structured format, then that it improves, it enhances what they're doing. So that's what we're trying to do. We're trying to provide the support, and not us doing the research, not us coming up with this, incredible research questions or, hypotheses, is so much supporting those efforts by helping them in the implementation side, evaluating the program, coming up with quantifying outcomes, so then that can be translated, not only in the academic world, but really generally outside. Because I think that we do want to work together. The question is how. The question is, do we have the time? The question is, we're doing a million things at once. So how can we get together and do this? And I think is that not only by providing not only by doing research and putting it up there in scientific journals, but really bringing it outside into the community, bringing it into the media, where hopefully they won't twist what we're trying to demonstrate. That's one way that we can then build on top of that. That's something that I see that we can all collaborate, because then that will bring into policy change. Hopefully that will be the ideal.
Yeah, you actually answered one of our audience members' questions, which was how can the data be leveraged to demonstrate the impact of these cuts? So I think you answered that question sort of perfectly there. I know the genesis of this discussion were the cuts to federal funding, but I would be amiss not to mention really scary change in HIPAA last week, where last year we had new rules in HIPAA that would require certain attestations in order to share reproductive health information with law enforcement and courts, and that was just overturned. So all of that has been vacated. So now there is not that additional protection for families and their reproductive health care information, and it can now theoretically be shared with law enforcement and courts without those additional protections there. But what was interesting and why I wanted to bring this up as a last point is one of the things that they didn't overturn were the protections around substance use information. So that's kind of one area that I feel like the current administration has been receptive to is substance use disorders, partly maybe because of the vice president's family history with substance and addiction issues. And a lot of their voter base does suffer under the opioid crisis. So I think, that may be one area where we could potentially meet in the middle where they understand the crisis there is just kind of getting them to also understand that it's not just in substance use, it's also in all of these other areas. So they're just trying to show the light at the end of the tunnel here that there is at least one positive piece there that we can see eye to eye on. In the last few minutes that we have left, I just want to open it to our panelists to each provide us with sort of their 1 minute closing thought or call to action for all of our listeners. And we can start with you, Angela.
Thank you so much. And I was sitting here thinking about what I would say in 1 minute, essentially, is that, as I said earlier, for me, this is hard work. And so, not hard work, but hard work. And what keeps me up at night at the end of the day, and I appreciate this panel, as does the audience, but what keeps me up at night is behind these numbers, behind these cuts, are people and lives. And it seems as if what is happening at the federal level is they're forgetting they're there to serve those very souls that are going to suffer across this country, Black, white, brown, whatever they are. It's not just going to be one people that suffers from the problems and the cuts that they're making. It's going to be all people. It's not just going to be the rich. It's not going to just be the poor. It's going to be all people. So what we really have to do is figure out how we strengthen the message so that they hear how drastically, use the data, use whatever tools we can to get the message across of what this really looks like. And these are the faces that you're going to hurt. These are the faces that are going to die because of this, literally die because of the decisions you're making sitting behind a table.
Motion detected at the doorbell.
That's it for me. Thank you.
Thank you. Dr. Belva?
Well, Angela said it all, I think. I love what Angela said, but looking at it from the research perspective, I think we need to go beyond what we always have been comfortable, right? NIH grants, NIH grants, NIH here, NIH there, SAMHSA. I guess we need to start moving outside of our comfort zone and really think about what else is beyond NIH. Foundations, I don't know, think about working with other countries. I mean, it's thinking outside the box. And in my case, for example, I just submitted to 2 different foundations. Well, it's not a lot of money, but guess what? I am going for what I want, not for what I think they want me to do, for what I think I should be going into. And then the second one is, because I'm in academia, is to really support my students, give them support. There's a widespread disencouragement of what's going on among the students. Many of them wanted to get involved into women's health, LGBTQ, focus on minorities, research or mental health or anything that might be. I had one student that actually is looking to see if she can look elsewhere outside of the country because her research is in psychology, focusing on the LGBTQ. So the point is supporting them, whether it's here or outside, because at the end of the day, they will come back. It's just for the time being, and it's not to discourage them and then have them do something else. So And I think that is something that we can do for the generations to come, because this is going to last for a short time, but there's more to come that we can work on. And so we need to start building, the next generation, so they continue the work that we're doing.
Thank you. Dr. Steinecker?
So during the pandemic in the State Operations Center, when I was running part of the operation for mitigation, there was a bumper sticker on the back of a laptop in front of me that said, "No one else is coming, you're it." And I now have that written as a sticky note on my computer. And that is going to be my message to everyone. Do what you can with what you can, wherever you can right now. Don't be passive. Don't just sit there on social media and post or repost things. Actually get out there and do something. So if you were a scientist, apply for grants wherever they may be in the world. There are multiple different countries in Europe as well as Canada that are supporting our scientists now at this time. If you are someone in the government, then reach out and work and share data and work on a way to be able to be creative, to pool your resources, your people, everything that you can do together to be able to save programs, services, and serve as many people as you possibly can. Partner with a CBO, partner with a private company, partner with a healthcare system. But it's going to take all of us to do something every single day. And I always say, focus on what you can do, not on what you can't do. So I might not be able to change any of the federal government decisions, but I certainly can make an influence wherever I am at in whatever I do that day. So that's my message to everyone.
Thank you. Thank you so much to our incredible panelists here. It was just an honor to be among these experts. And thank you to the Women's Caucus of the American Public Health Association. I apologize to some of our listeners. There were a ton of questions. We couldn't get to all of them, but I can work with the Women's Caucus to see if we can send written follow-up responses to you. And I believe this is part of a series of conversations. So for the next one, maybe we can answer some of the questions that you all sent in, but thank you again, and we hope you'll join next time.
Thank you.